good afternoon, depending on where you're located. And thank you for telling us in the chat where you are located. I'm Joyce Garippa. I'm a conference producer here at ICD Events. And I actually produced the Healthcare Burnout Symposium on the East Coast and the West Coast. It's my pleasure to welcome you today to Retaining Women Physicians, Halting the Exodus. Again, reminder, please do keep yourself on mute. And of course, you can turn on your video if you'd like. Before we get started, I mentioned the Healthcare Burnout Symposium because Diane, our speaker today, was supposed to be a speaker at our November event happening November 20 to 22 at NYU Langone, but unfortunately she had a scheduling conflict and cannot join us for that event. And so that's why we asked her to put this meeting together today so we can hear parts of what her session would have been like in November. Brian Sexton actually is the chair of our New York City event, and I do hope that many of you on the call today can join us for that event, again, November 20 to 22 in New York City at NYU Langone. We do have a packed agenda. You can visit icdevents.com to learn more about this event and all of our other wonderful events. There will be time at the end of this session for Q&A. I ask that you put your questions in the chat. Diane will take those questions towards the end of her session. As a reminder, you will get all of the slides and the recording of this session, and I will send that out to you after this session is over with. A little background on Diane Shannon, Dr. Diane Shannon, before I have her take it away. She has personal experience with burnout, and her desire to support physicians motivated her to become a certified coach 5 years ago. She runs a coaching company for women physicians and works with frontline clinicians and emerging physician leaders who want a sustainable, balanced way to work in medicine. She helps clients to improve their work-life balance. She addresses imposter syndrome and self-doubt. She identifies and works towards personal and professional goals and builds careers that are satisfying and sustainable. In addition, she continues to advocate for system change through writing and speaking, hence she's speaking today. She is also the co-author of a 2016 book, Preventing Physician Burnout, Curing the Chaos and Returning Joy to the Practice of Medicine. So please, Diane, the stage is yours.
Thank you so much, Joyce Ann. I am really thrilled to be here today to talk about a topic that's very near and dear to my heart. So today what I want to do is share some observations and also some data about what is under the exodus of women from medicine and what we might think about in terms of solutions. And I want to share first why this is so important to me. First of all, I am a patient, and I have noticed over the past number of months, years recently, that it has become harder and harder for all of us who are patients to access our healthcare team. So the access problem is something that's on my mind as a patient. In addition, I left clinical practice more than 20 years ago because of burnout. And when I left, I did not see other options. There was no discussion at that point about burnout, about wellness, about support, about mentoring or coaching. And I feel really passionately about helping physicians have more options so that they can have a long-term sustainable career and be healthy at the same time. So this is something that I really care about. And I also care about my colleagues, my physician colleagues, that every day I am talking with physicians either through my writing work or my coaching work, and I hear what it's like. And there are many physicians who are suffering today. And I want to turn that around. I want to be part of what the movement that is trying to turn that around. So let me get started. First of all, I have no disclosures. And today what I want to do with you is to explain some of what drives the higher burnout rates in women physicians and also the higher turnover among early career women. To talk about where gender role expectations fit in here and then also to focus on strategies that may help to retain women physicians and to help them thrive. I want to acknowledge first that gender is just one of the challenges that people may face. We have lots of different identities. And I'm going to be speaking today about gender and how women in the workplace, in this workplace in medicine, are facing and have faced obstacles. But there are many other obstacles, so that women who have different racial identities or ethnic identities or sexual orientation identities, there will be piled onto gender those additional challenges that they're facing, those obstacles they're facing. So I just want to identify that and say that, and also that I'm defining women here as people who identify as women. So what we're seeing, this is a piece that was put out in August of this year by the AMA. And they have an internal survey that they do with thousands of physicians across health systems in this country. And their data, their most recent data, show that there has been a bit of a drop in burnout from the previous year, from 2002 to 2003, but there's still a gender gap. And this was something that that is also, these are the data from that particular survey, so that you can see that burnout is higher in male physicians, or I'm sorry, in female physicians. Female physicians, here in green, are less likely to feel valued. However, the intention to leave in this study was higher, a little bit higher in the male physicians. I found another study that also found that male physicians had a slightly higher reporting intention to leave within the next 2 years. Either way, 30%, 33% or more of physicians are saying they may be leaving their position within the next 2 years. That is huge and a big red flag. So here's another piece of the data that I wanted to share, which is, this is from a relatively small study, but it is one of the few that we have, looking at retention at full-time FTEs at 6 years after completion of training. And you'll see that in this study, 100% of the male physicians were still working full-time, but only 62%, 6 out of 10, were still working full-time if they were women. So I was really intrigued at the beginning of the pandemic, which was soon after I began coaching, as to why the burnout discrepancy between gender was actually getting bigger. So we always had higher rates of burnout in women physicians, but that had begun to increase. The difference between the genders was increasing, and I wanted to understand why. So I set out to interview, actually I was just going to interview 3 women physicians just to get an idea. And it was so interesting. I ended up interviewing 30 women physicians across the country, different fields, different ages, different regions of the country, different ages. And this was during 2020, so very much affected by the pandemic. I pulled this information together in a white paper. You can contact me if you would like a copy of it. I wanted to share some of what came out of this because it has only been reaffirmed by what I've read in the published literature and also my experience working one-on-one and in groups with women physicians. The top challenges that they identified: work-life imbalance or lack of harmony between work and personal life, many internal struggles around self-doubt, imposter syndrome, guilt, mom guilt, and perfectionism. Some of these externals around gender bias, sexism, sexual harassment, the motherhood penalty, which I'll say more about in a few minutes, productivity pressure, which in my mind has only increased in the 4 years since I spoke with these women. So that pressure to do more with less, to do more faster, to see patients faster, to see more patients per day has only increased. And then childcare limitations, which were acute during this period of time. I also wanted to share some of the quotes because I thought they were so revealing. This first one it's really about, women seen in a different light. So when they brought their style of leadership, which they tended to be more collaborative, less top-down mandate, and they were told that was not effective and that they weren't getting things done. Now, this is despite the fact that the research in the business world shows that servant leadership, where you are supporting your team and bringing people together, that's actually a more effective way to lead. The women that I interviewed also introduced me to this term called manels, which is an expert panel that is made up all of men. So why is it that this wasn't identified, that there was a voice being left out? And this, which I thought was so poignant, so many of them told me they felt alone and felt like they were the only ones failing at this. Why couldn't they keep it together? Why couldn't they get their work done? And yet, most of them were telling me this. And this is one of the things that I hear over and over again. And when I run groups for women physicians, this is what they tell me is one of the most valuable parts of that is the ability to connect with others and realize other women, even in different departments, different fields, different organizations, are feeling some of the same thing and running up against some of the same obstacles. They also then have a chance to share what they have found has worked. So I'm going to dive now into some of the published research on this, on kind of what are these drivers that explain why burnout is higher in women physicians than their male colleagues. So this is just an example of a study that was done about gender bias. The researchers went back and looked at recordings of grand round presentations in hospitals. And what they found, there was a huge difference between when the title of the speaker was used and when it was not. So when they were introduced using their title. And women tended to introduce men at a rate that was almost 100%. Women introducing women a little bit lower. Men introducing men was around 75%. But when men were introducing women, it was only about 50% of the time when they actually used their title. Now, you could say, well, that's only a title. It's not that important. But the title establishes an expertise. And rather than it being a more informal introduction to that person. So it does undercut at their expertise right when they're about to begin their talk about something that they are actually very expert in. Pay. It's been identified or estimated, I should say, that there's about a $1 million difference in the amount that physicians make based on gender. There's also this, what would you call it? This phrase, motherhood penalty, which relates to or explains when a woman is overlooked because it's assumed that because she's a mother, she won't want to do that extra task or that special project or take on a higher leadership position, when in fact that's not true. And also, there is a difference in work tasks. And this, I think, is really fascinating research that's coming out. And what it's showing is that women do different work. Women physicians do different work in some ways. So, for example, we know from many studies that women physicians spend more time in the electronic health record. And you could say, okay, we need to help women physicians become more efficient at using the electronic health record. That's going to solve the problem, unless you look more closely at the data. This is a study that from 2022 that looked at inbox messages. What they found was that women physicians receive more messages from patients and from staff, so that their work task in terms of dealing with the messages in the electronic health record, the patient portal, is higher. And not only that, there's more underneath that. So this is a great article if you want to take a look at it by Dr. Lisa Rottenstein. It was published last year. looking at primary care and the activities that go into primary care, what's reimbursed, what's not, and found that women physicians are doing more communication. They're spending more time with each patient. Another study found about 2 minutes more per patient. And so those things are not being compensated for. They're not being reimbursed. So it's looking at how could we shift that so that some of those very valuable tasks are actually paid for. And so women aren't having to do extra work just to keep up. Now, I was lucky enough to interview Dr. Rottenstein on my podcast. So this is episode 116. If you're interested, and I have a QR code at the end where you can find this podcast. But if you look up the title, you will find it. And she shared some really interesting research she's been doing in this area. One of the pieces that I'll share today is that they found that there's a difference in patient expectations about communication through the patient portal based on gender. So women physicians, if they were, their satisfaction, patient satisfaction and experience scores were dependent on whether they communicated back and forth in the portal, how quickly they responded, the volume of their messages. That affected their patient experience and satisfaction scores. It did not affect the male physician scores. So there is this expectation that patients have about women physicians and what they're going to do, and women physicians are responding to that. So they are doing more work to communicate with patients. Then let's turn our attention to what happens at home. In the US, we are socialized to do more of the work at home. That's just how it's been. That's how it continues to be in some ways. So the data shows that women physicians spend about 8 hours more on home and childcare than their male colleagues. They're also much more likely to have a partner that works full-time outside the home than their male colleagues do. And they are usually the ones covering childcare gaps, or I should say more often covering those childcare gaps. So if the nanny is unable to come, if childcare or their childcare center is closed, if a child is sick, they are more likely to lose out on work and cover that than their male colleagues. This is another great article. This was in Harvard Business Review in 2022 by Jessica Dudley and some other physicians, looking at why are women physicians leaving. And what they identified as important was that women physicians had lower scores in these 3 areas. So let me explain a little bit about how defining these terms. Alignment was about the values that the individual has aligning with the values of the organization. And so where there was congruence there, you'd have a higher alignment score. Resilience included 2 basic ideas. One is finding meaning, being able to find meaning in your actual work. And the other is the ability to recharge outside of work. So women had lower resilience scores. And finally, intent to leave. Women had, intent to stay, sorry. Women had lower scores in intent to stay. Now, this is different, obviously, than the other study that I showed earlier. And part of that might be the time frame. One's talking about 2 years, one's talking about 3. And also that it's not clear whether the definitions are leaving your position or leaving medicine or cutting back on clinical time entirely. So there's a difference in definition there. But in theirs, there was lower intent to stay. So I've given you a lot of data about what's underneath. And you could ask, why should organizations care about this, right? And probably the biggest driver right now, I would say, is that this quote from this article in Harvard Business Review, they can't afford a mass exodus of women physicians. Now, right now, at this point, women make up more than 50% of the medical school matriculants. As that continues, as generations continue to go through, there will be more and more women physicians finishing medical school, going through training. And if we are losing so many of them, 6 out of 10 who've cut back either part-time or left entirely, we are going to be in a bad place. We already knew years ago that a paucity of physicians was coming, a deficit of physicians was coming, and this will only exacerbate that. So it is important. Now, this requires taking a longer term view than just looking at this quarter's profit margin. So it means investing now to retain physicians, including women, in the future. And we know that recruiting and hiring and onboarding a new physician costs somewhere around $1 million. However, if individuals who are in leadership are looking just at this quarter, they may not be thinking about preventing that $1 million loss. They may be thinking, I don't know about investing in a program right now that would help support. So this is where we need for people to be taking those in the finance and in the decision-making to take a longer term view in what's going to stabilize and create a viable physician workforce. Now I want to move on to potential solutions. So what do we do about this? I like to think of it as a 3-step strategy for change. And so that's what I'm going to offer you to think about. The first step is embracing a paradigm shift, which I will explain in a moment. The second is to begin advocating for high-level changes, changes at the culture level or the organization level, at the regulatory level. And then third is to adopt very specific strategies that are dependent on what the local needs are. So not just saying everyone should adopt this particular policy or strategy or flexible schedule, but to say you need to find out and then adopt those specific strategies that are going to meet the needs of the women physicians in your local clinical unit. So starting with step 1, embracing a paradigm shift. And I want to begin by sharing a slide from Robert Wood Johnson Foundation that I found really illuminating when I saw it a number of years ago, in helping me to understand the difference between equality and equity. You may have seen this slide or one like it. The idea is that equality is about everyone having the same resource. So exactly the same resource for each of these 4 people means that only one of them can most effectively use the resource. Equity is instead about each person being given the resources and support they need to be productive, to be successful, to be at their best, to be able to bring their best potential to whatever they're doing. So hold on to that idea that what we want in the end is to have everyone working at the top of their license, at the top of their potential. And to do that, we may have to provide differential support and differential resources so that everyone can do their best. So the paradigm shift. Here I want you to imagine let's say 32-year-old physician, and she's married to another physician. She's just had a child and is returning to work after 10 weeks. She didn't want to take a full 12 weeks because she felt guilty about leaving her colleagues without support. And so here she is coming back. She wants to continue breastfeeding, and she honestly doesn't know how she's going to do that. She's thinking, I don't have a break during the day. How am I going to refrigerate the milk? How am I going to manage all of this and go back to work? the first day back, I've got a full schedule and I'm not sleeping because I've got a newborn. So that is where I'd like you to think about when we start, which is the culture seems to be, let her figure it out, sink or swim. Somehow she's going to navigate coming back to work and with a newborn with very little sleep, figuring out how to navigate being a new parent. And instead, what if we were to take the approach and use the lens of what do we need to do to retain women physicians? And I just want to pause for a moment and let that sink in and see if there's something that rises to the top in terms of an action step. So put yourself in the shoes of that woman. And let's say she, as I mentioned, she has a husband who is a physician. He's back working full time, getting full pay. She's having to take breaks in order to pump and therefore has cut back on her RVUs. She's getting paid less. She's stressed out. Maybe she's having trouble even maintaining her milk supply because she's stressed out. And they are parents of the same child, but their experience at work is completely different. So if you wanted to help her to stay and create a loyal employee who would remain even after she was finished this newborn period, what would you do? So just pause for a moment, think about that, maybe jot down some ideas. And I'll move on to step 2, which is about advocating for high-level changes. And again, these are on the cultural or organization or societal level. And there are 3 that I think are important. I should say there are many that are important, but I've chosen these 3. So one is creating a belonging culture, and I'll say more about that. The second is addressing time pressure. This was one of the key solutions that was identified in that Harvard Business Review article by Jessica Dudley and others. And finally, to identify local needs. So what that means is, again, not assuming you know what women physicians need for support at different phases and different challenges, but to ask them. And so that requires interviewing or surveying or shadowing, but finding out from those individuals what their specific challenges are and what would help. Now, I want to say more about the first 2 bullets here. Creating a belonging culture. There is a podcast, you might have heard of it, called Work Life by Adam Grant. And there was an episode that was about creating an anti-racist workplace or organization. And I highly recommend it. You can find that on this website, or you can just search for Adam Grant, Work Life, and then anti-racism. His guest was a psychologist, John Amucci, and this is a quote from his guest. He said, "Your culture is defined by the worst behavior you tolerate." So what that means is that if there's disrespect, if there's a bias, if there are microaggressions going on, and no one is calling them out, and leadership is not taking a stand against them, that will then become the culture in the organization. So if we want a belonging culture, it has to be one where everyone, including leadership, is dedicated to treating everyone with respect and civility. And so I recommend this podcast. It really is very illuminating, but that's something to think about. How do we create an organization where everyone feels they belong, have a voice, and are respected and are treated civilly? And next is time pressure. This is a huge problem. I think it's probably the number 1 problem that physicians come to me for with coaching that we focus on. It just becomes so much more of an issue with the productivity pressure that everyone is under these days. So here are just some ideas. really considering the compensation formulas. For example, if physicians are paid on an RVU basis, and that is calculated over 52 weeks, that sends the message that they don't need to take any time off. If they do take time off, then they are going to have to make up for that because the target is at 52 weeks instead of 48 or 46, something that would allow them for vacation time. Second, team-based care, which is where there's a multidisciplinary team where everybody is working at the top of their license, and the organization is investing in obtaining and training support clinical staff so that physicians are free to do the work they're meant to do. And this would require, for example, that enough medical assistants who have been trained in medication reconciliation so that they can help out with that part. I have physicians that I've talked to who are now rooming their patients because there just aren't enough medical assistants. And what they hear is, well, we don't have the money to pay them more, and so they keep leaving. Well, that's a money problem. It's true. And it's one that if you're thinking we want to prevent burnout and prevent this person, this physician from leaving, this is where we can invest some money. Third, optimizing the EHR and potentially using shadowing. So that is where either a super user or an IT tech person sits down with the physician, watches what they're doing, and the physician can say, oh, this is so frustrating, or this is inefficient, or I don't use this thing, or how do I do this more quickly, and get immediate feedback or immediate help on something that is really wasting their time. The Getting Rid of Stupid Stuff initiative, this was something that was begun in a health system in Hawaii. And the idea is that nurses and doctors can nominate frustrations, inefficiencies, things that are just irritating or just wrong, and a team will assess them and begin to chip away at addressing those issues. So one example they give is that for a long time, the nurses in the NICU had to do like 5 different checks when a child's diaper needed to be changed because it had been set up for incontinence in adults. So once that was brought to the attention, it was quickly changed, and suddenly there were 4 clicks they didn't have to do anymore. Last, recognizing and compensating for invisible work. And I will just say a little bit more about what that is. And this comes from Dr. Shikha Jain, a talk that she gave in 2022 at the Women in Medicine Summit. And she continues to talk about this notion of invisible work and how important it is. This is work that is not compensated and does not lead to advancement. And women tend to do this work. It's being on a volunteer committee, being asked or voluntold to be on a committee, and you end up doing all this work or maybe even chairing the committee, representing the department because you are the only, right? You're the only woman, you're the only person of color. And so you're representing the department whenever there's a recruit coming in and you're taking them to dinner, it's you. Being the token secretary, scribe, or party planner, just because you're a woman, you are asked to do this or expected to do it. Or the general expectation is women are going to do it. And the issue is that this is not recognized, it is not compensated, and it takes time and energy away from those other activities that would lead to advancement or compensation. And 3 is to look at specific strategies and see what's going to work. And again, this is informed by needs. So you need to ask the questions first. What is it that these women in these clinical units need to support them so that we can retain them and they can thrive? So you have to ask that question first. But I wanted to share some examples of what organizations are doing. So one is to really consider, can you offer flex part-time shared positions? And You may, there are places that some of my clients have worked where they say, no, we only have full-time physicians. You can't do anything else. What happens? They leave. So looking at places where there could be some of those options so that you can retain those women. And one thing to consider is that having a very, very busy home life, especially with children, happens over a course of period of time. Things change over the course of a woman's career, and she may be able to do full-time work at another point. Adopting policies to support parents who are working, whether that's caregivers of elderly parents, or whether it is of children or people who are ill, and then expanding support. And I'm going to say more about the second and third bullets here. So what are some policies that might be helpful? Looking at parental leave. It is very opaque, I will say that. And if there's a resident who is interviewing and really this is important to her, there's a whole question of, do you ask about it? How do you get find out what the exact policy is? PTO and vacation. I just worked on a toolkit for the AMA Steps Forward program, and many of the people we interviewed called it pretend time off because it's not actually paid and it's not actually time off. How do we help and support and have policies that allow for physicians to truly take time off? Looking at scheduling rules. How much flexibility can a physician have in terms of when they start clinic, when they finish, what days they work, and even when they have, like, for example, for primary care, when do they have their annual visits versus acute? And that can make a big difference in what their day feels like. Having a float pool. Now, again, this is investing today to save money in the future. But, if you think about it, we can anticipate and could estimate at any one time, X percentage of physicians are going to be gone, right? They're going to be on vacation, sick leave, parental leave, bereavement. So why not acknowledge that and hire a float pool to cover so that you're not burning out those who are covering while that person is away? And finally, lactation support. And this I heard over and over again. I actually wrote 2 blog posts about this because I was hearing that lactation support was such a big issue. And so I interviewed the folks at UCSF, Diane and others, about this program that they started. And it provides for a 30-minute break per half-day outpatient session. And not only a break, it provides RVU credit so that they are not losing salary while they have a newborn and are working hard to continue to breastfeed. It also provides clean space and a way to reserve the room where you can go to pump and have refrigeration. And the feedback they got was just so incredibly positive. Then people talked about feeling loyal to the organization and grateful that this had been set up. And again, it's not that they're using it for years and years on end. This is a number of months or a year even that they would be using this policy, but made a huge difference. And if you want, you can check this out at my website on my blog. Expanding support, right? So what I've been hearing so much is that mentorship is incredibly important and often hard for women physicians to find as they're wanting to move into leadership positions. So really setting up something that's formal. Ensuring there's access to coaching and also mental health services that's easy to access. There are organizations, there's one that I work for, where they provide an app that sets them up as part of their employee benefits program with a whole list of services, including free one-on-one coaching and therapy. And then finally, offering some opportunities for collegial connection. There are organizations that pay for a meal once a month for a small group of physicians to get together just so that they have more support and create those connections that have been so severely broken with the pandemic. And as an individual coach, I had to mention some individual strategies. So these are what people can do. First is to think about where we have agency. And I believe there are three places where physicians have agency: who we show up as every day, how we lead, whether we have a formal title or not, and how effectively we advocate for change. Do we know how to communicate with the decision makers to do the best job we can to get things changed, to make requests? And how do we show up as our best self? One of the things that I do with my clients is to say, what does your A game look like? Tell me what I would see if you were on your A game, and then what I would see if you weren't. What's your energy level like? How do you respond to unexpected events? And then ask them this question: what are the preconditions that make it more likely you are going to be on your A game tomorrow? And then help them to create a very small experiment to try to improve that in one way. And so it really is about maybe taking the blinders off all the things you can't change. And we know there are many that are driving burnout, and looking at what you can change. And I have seen this make a huge difference, just small changes adding up to a big impact. So how might you take this information and create an action plan for yourself? First is to think about a specific challenge that you might like to target. Maybe it's something you've observed either for yourself or in your organization you've seen that women struggle with. Maybe it's something I mentioned. And so think about what that challenge is. Maybe it's, for example, lactation support. And then 3 very specific steps that you could take to move that forward. That might be sending an email with a decision maker to review a policy or find out what's available in terms of lactation support at your organization. And then before you take steps, think about the obstacles that you may face and how you might get support to overcome those obstacles. So setting yourself up for success to move forward with your action plan. Today, what I hope to have expressed to you is that all physicians are facing increased stress today. I hear it day after day from all physicians in all fields. Women physicians face additional gender-specific challenges. And the hope is there are specific steps that you can take to reduce burnout and reduce the intention to leave. And so that's where I hope to leave you, is with a sense of wonder about what could happen and a sense of hope about steps that you might take. If you want to talk about a specific challenge or talk through what those action steps might be, I'm happy to speak with you. I have a free consult. This QR code leads to my schedule, and you can set up a 30-minute time with me. And you can do that through my website, dianeshannon.com. And finally, my podcast. And this is a QR code that goes to my podcast. As I mentioned before, I've been speaking with many researchers about some of the data that underlies the difference in burnout rates. And this is one way to listen while you're doing something else. And so that is the end of my presentation. I'm looking forward to taking questions. And I want to thank you for joining today and for your attention.
Thank you so much, Diane. That was fantastic. And I love the actionable items that you presented. I also love that quote. I wrote it down. I'm going to use it over and over again. Your culture is defined by the worst behavior you tolerate. That is it right there. Wow. Wow. So for our audience, if you have any questions, I know you're thanking Diane in the Dr. Shannon in the chat. But if you have any questions, do feel free to put them in the chat. We will hang on here for some questions.
Oh,
And
I
by
see.
the way, we are having at our New York City Burnout Symposium, Diane, you mentioned it in your presentation, AMA is doing that Saving Time boot camp. And so a lot of people are really looking forward to that particular session.
Excellent. I saw a hand up.
Oh, did you?
Hi, and first of all, it's good to see you. Liz Bohm with the Heart of Safety Coalition. I'm curious, I know you work mostly one-on-one with folks, but as you've been doing the research, some of these things just seem so straightforwardly duh, right? And yet we've not been doing them for decades. We've not been doing them. What kinds of barriers do you bump into? Are they more systemic? Are like actual pushback? Are they ignorance? Are they, the financial arguments or that's not fair kind of arguments, the, equality versus equity kind of arguments? What do you bump into that makes it hard to put this kind of thing into place?
Yeah. Thank you, Liz, for that question. And I will say, I have begun working also in groups. And so I run group coaching programs for organizations so that we can have more impact. I think the two things come to mind. Number one is finance, and it is really tight right now. And what I'm hearing is that more and more of the wellness councils and committees and departments are being cut back. Their budgets being cut. So there's less and less being put into investing in preventing and reinvesting and retaining. So that's one. The other, I think, is the culture of medicine. And I came across some research I was doing, this photograph of the trainees back in probably 1900. And this was at a local Boston hospital. And it was a picture of maybe 20, 25 individuals, all white men, all wearing white. And the caption talked about how they came to the hospital, they lived there, and they were not allowed to be married or have children. And they lived there, 24 hours a day for a year. That's where we come from. And so it's like we have just tacked on more and more over the decades, but we never have gone back and said, why should self-sacrifice like that be where we are? And why should it be just that group of people, what worked for them and that self-sacrifice? Why should that be the foundation of how we train and how we practice? But I think vestiges of that still exist. So it's kind of like, well, the sink or swim, we made it through. Why should we, why should, and I've heard this especially around when a woman is coming back, she should have to make up the call she missed. And if you think about that, is so backwards for someone coming from medical leave or parental leave, and now they have to double up their call. I mean, what a setup for failure. Thank you for the question, Liz.
Thank you. And thank you for putting a focus on this. It's so important.
All right. Well, any more questions? You can turn your camera on,
I'll go down.
audio on. All right. Well, again, Dr. Shannon, fantastic. Thank you so very much. I was jotting notes down. I love the presentation. I'm so sorry you're going to miss New York City in November. I really would like to see you in person. So thank you. Thank you. And again, thanks to all of our attendees today. You will receive the recording as well as the PowerPoint presentation. And I do hope to see many of you at our ICD events. We have the November Healthcare Burnout Symposium. We also have our Hospital at Home Leadership Summit in December. Visit icdevents.com for more information. But again, Diane, again, thank you. And thank you to all of you. And we'll hopefully see you all soon.